Hello, my beautiful wound warriors. Welcome back to Diabetic Foot Files, the podcast where we try our best to help save limbs, expose bad biomechanics, and just talk about what nobody really talks about when it comes to wound care, to be honest. Today's episode is about a particular group of patients that often I really didn't hear that much about, but I mean, I guess doctors who really specialize in pressure wounds know, but it's patients who are wheelchair patients, seated patients, patients that are in wheelchairs, patients who are not able to walk. Because we actually, as wound care providers, see a lot of them. And because these ulcers don't require like weight bearing, these ulcers that they acquire, especially if they're in a wheelchair, is due to pressure, time, neuropathy, and sometimes neglect, to be honest. And we have to also give them a voice and also look out for them. So wheelchairs, people misunderstand it, and it can actually become an ulcer generating machine because I've had quite a few patients who have developed ulcers from their wheelchair due to pressure points. But we're going to deep dive how the wheelchair patients develop diabetic foot ulcers, how different ways their mobility can be lost, why deformities worsen in seated positions, how heel and lateral foot ulcers form. That is one of the common spots, okay? And limb salvage. That's the whole point, okay? So, how do patients end up in a wheelchair? So, wheelchair is not a diagnosis, okay? It's kind of just like a final common pathway. So, patients end up in wheelchairs for multiple different reasons: stroke, spinal cord injury, traumatic brain injury, advanced diabetic neuropathy, Charcot collapse, severe osteoarthritis, advanced peripheral arterial disease with rest pain, amputation, and trauma, like let's say motor vehicle accidents. Some patients are temporarily in a wheelchair, some are permanently non ambulatory. But here's the mistake that some people make: they assume that no walking means no foot ulcers. And that assumption can cost people their limbs because they are very prone to getting foot ulcers. So, let me give a quick short history about the wheelchair and why the design of the wheelchair matters. The wheelchair was invented not for pressure redistribution. One of the earliest self-propelled wheelchairs were built by Stephen, let me just pronounce his last name properly, Farfeller. I'm just going to spell it Farfsler. And he was a paraplegic watchmaker in the 17th century. And his goal was movement, not limb preservation. He wanted to move. And modern wheelchairs evolved for mobility, for speed and independence, but not for diabetic biomechanics. So that means that the foot position, the heel contact, the lateral loading, and the prolonged dependencies were not part of the original design philosophy of the wheelchair. And that's why some wounds happen while you're on the wheelchair. So let's talk about the types of wheelchair and ulcer risk. Not all wheelchairs create ulcers the same way. So manual wheelchairs often place the feet in a slightly plantar flex position. The foot is externally rotated and resting on a rigid foot plate. Okay. Power wheelchairs keep the patient seated longer. So increased duration causes more dependent pressure ulcers. Reclining wheelchairs shift pressures to the heels. Okay. That's why you should have a heel offloading pedal or a heel offloading device. Tilt in space chairs can help, but only used if they're correctly. But the problem is not the chair. The problem is unrelieved pressure plus neuropathy plus time. So why wheelchair patients get diabetic foot ulcers that are diabetic, okay? So let's be clear. Wheelchair patients get foot ulcers because one, constant heel pressure on the foot plates, two, lateral foot pressures from malpositioning, three, the plantar flexion contractures, four, from adductor varus deformities. That's one I had to deal with this past week. Five, the loss of protective sensation. Six, the inability to visually inspect their own feet. And seven, being caregiver dependent. foot care. Like your caregiver has to take care of your feet. So it's not that steps are required or the patient has to be weight bearing to get a foot ulcer. It's pressure alone enough. So in seated patients, heel ulcers form differently than bedbound patients. So the heel is pressed against the foot plates, the metal bars, and the rigid surfaces, or dangling unsupported. And neuropathy removes the warning signals, and ischemia removes the repair mechanism. So the heel, with minimal fat and poor blood supply, breaks down very quickly. So well, let's talk about positioning. So when I'm talking about pressure mapping, there is a pressure mapping when it comes to wheelchair, but pressure mapping isn't a machine, but you have to think it's a way of thinking. It's the ability to mentally trace and figure out where the forces are applied and how long they're applied and whether the tissue can tolerate it. So pressure equals force over area over time. So wheelchair patients lose time variability. So they sit in the same position for hours and sometimes days, and that's how ulcers can form without a single step. So, like I said, keep this in mind. Patients that are seated in the wheelchair, their foot is not in a neutral position, okay? Their foot is usually in a plantar flex, externally rotated, unsupported at the heel, and laterally loaded. So gravity pulls the foot down, the foot plates try to push it back, and then the neuropathy removes the feedback. And this creates like static pressure zones, which are like the most dangerous type. So let's talk about the primary pressure zones in wheelchairs patients. Zone number one that I see most commonly are heels. Okay, heel ulcers. So the heel is the number one ulcer site in wheelchair bound diabetic patients. Why is that? Because of the minimum fat padding, the poor blood supply, the constant contact with the foot plates and the wheelchair. And the pressure sources include the rigid foot plates, the dangling heels, the metal crossbars, and the prolonged plantar flexion. And unlike bed ulcers, wheelchair heel ulcers often are deeper, more ischemic, and slower to granulate, in my opinion. Next zone for wheelchair ulcers are lateral foot and fifth digit. This is one of the most missed pressure zones. Like I said, I'll never forget this one patient, but he wasn't wheelchair bound. It was bed bound, but it was the lateral side of his entire foot was dead, the whole lateral side because they didn't turn him over, and he was contracted. It was kind of very the foot they couldn't save it. They had to do a below the knee amputation, and I think it progressed to above the knee amputation because of his perfusion. But always keep that in mind. Anybody who has limited mobility, you have to check every pressure point that is feasible, okay? And should be checked daily, okay? If not, that's malpractice and neglect. So, long story short, let me go back to the pressure point. Zone two is the lateral foot and fifth digit. This is, like I said, one of the most missed pressure points. So, when the foot externally rotates, the pressure shifts laterally, and the fifth toe becomes the bumper, and the ductal varus deformity, which rotates the toe inward and downward and exposing the lateral skin. And this is a place where I see a lot of nucleated hyperkeratosis, which I have dealt with even this past week. So pressure plus friction is going to cause an ulcer. The nucleated hyperkeratotic lesion that is along that fifth digit is showing you, hey, I could become an ulcer. I'm almost about to graduate to become an ulcer. Right now, as a nucleated hyperkeratotic lesion along the lateral fifth, fifth digit aspect, secondary to adductor varus deformity, is a pre-ulcer, okay? Next place where we can get ulcers as a wheelchair patient is the foot plates don't really care about the anatomy. The dorsal toes. So another people don't really think about is the dorsal aspect of the toes. The dorsal toes rub against the straps. Sometimes people have straps. The shoes uppers and the rigid plates. And neuropathy patients don't pull away. They can't like say, oh, this feels weird, or I can feel some friction or some pressure on that area. So dorsal ulcers don't appear suddenly, but the pressure has been there for weeks. Next zone is the posterior heel cord and along the Achilles. We already talked about the heel, but along the Achilles, and those are ones are really bad. So the plantar flexure contracture shifts the pressure posteriorly, and this area is very overlooked as well. I know sometimes people have very rigid contractures due to certain neurological injuries, but you have to try to lift their leg and look and inspect the entire lower extremity, okay? For any pressure points, any areas of redness. And the skin in the back of the posterior along the Achilles is thin and movement is limited. So the breakdown here often is deep before it's visible, okay? So why does contractures change the pressure mapping of things? The contractures are pressure multipliers. So plantar flexion contractures increase heel and forefoot pressure. Inversion contractures increase the lateral load. Adductor varus isolates the pressure on the fifth digit. And the more fixed the deformity is, the smaller the contact area, the higher the pressure, okay? So you have to mentally pressure map your patient when you see them. So you don't need fancy equipment. You just have to ask certain questions in your head. What part of the foot is touching something right now? Okay. Can the patient be repositioned independently? How long do they sit without adjustment? Where is the skin thickening? Callus is a pressure history, and then ulcers are pressure outcomes. Okay. So when it comes to pressure redistribution, we're not talking about just offloading. Redistribution is not removal, okay? So strategies include like padded foot plates, heel suspension boots, silicone toe sleeves, lateral foot wedges, custom AFOs, which I love. And if the pressure just moves, you must know where it is being moved to, okay? AFOs. We'll get into an episode about AFOs, I believe, but in wheelchair patients, they actually do end up still having AFO because they have certain rigid contractures of their lower extremity. AFOs are not just gait devices, they are pressure control devices, okay? Ankle and foot orthosis. So a properly classed AFO stabilizes the foot, reduces the plantar flexion, limits the varus, and redistributes the load away from the ulcers. A poorly cast AFO, because I've heard this from patients. Some AFOs have caused patient wounds because they were poorly cast and not placed in the biomechanically correct alignment to prevent ulceration. So, what are some red flags when it comes to pressure mapping in your head when you're trying to figure out what areas are high risk for a patient in a wheelchair? Any area that has recurrent not recurrent ulceration and recurrent callus formation. Y'all gotta forgive me. Nobody's perfect. I get tongue tied a lot. So recurrent callus formation in the same location, ulceration despite offloading, new ulcers after bracing, heel ulcers in seated patients, lateral toe wounds without trauma. These are areas where pressure mapping has failed and you have to redistribute the pressure, okay? So, as a caregiver and thinking about the healthcare system, wheelchair patients depend on others. They depend on us and their caregivers and their family. And if caregivers don't reposition the patient properly, inspect the lower extremity daily, even twice a day, and understand the device that the patient has to use, the pressure wins. And in a limb salvage team base, we have to make sure and not forget about these patients, okay? Because just because they're not walking does not mean that they don't need their limbs. They still need their limbs. We're not going to forget about them, okay? So our wheelchair patients, y'all are also another priority of us, okay? But long story short, I want everybody to always remember too that there are some heel precautions. So for wheelchair patients, heel protection should be continuous, not just in the bed. It should be lightweight, non-shearing, and adjustable for the patient's foot position. Things like heel cushion, heel suspension boots, custom padding on foot plates. Now, what's another thing we need to address when it comes to that? Okay, so callus. The calluses or the pre-ulcer lesions on the wheelchair patient. So treatment for that is very multi-layered. So you're gonna have to Sharp excisional debridement. We do not want sharp excisional debridement until healthy, viable bleeding tissue. No, we don't want that, especially if it's just a callus. We don't really need to make the patient bleed. And then also you need to know what anticoagulation therapy the patient is on. So also offload that area. So let's say you need to offload the fifth digit. Padding, silicone sleeves, even a donut pad would be helpful. Foot plate modification. You have to modify the foot plate that the patient is in on that wheelchair. Make sure the patient is correctly positioned, and then orthotic and bracing, okay? Think about that, okay? So if you needed to bride, if you only debride and just don't redistribute the pressure and think about the biomechanics, ulcer slash callus may come back. Most likely will come back because, one thing about pressure, it remembers. It's like an elephant. It never forgets, okay? So, when it comes to casting a patient for AFO in a wheelchair, casting for a patient with an ankle foot orthosis in a wheelchair requires intention. And I think a lot of people forget about that because they'll be like, oh, they're in a wheelchair. They don't need an ankle foot orthosis, but they do. So when it comes to casting a patient for AFO in a wheelchair, and they're in a wheelchair, the foot must be placed in neutral dorsiflexion. Neutral dorsiflexion. You have to correct the frontal plane position and reduce the adductor varus, okay? You must account for the contractures, the tone, the spasticity, the skin fragility, and the edema, okay? So the goal is not about perfection. The goal is about pressure, redistribution, and stability for the patient. So I hope everybody really remembers about our wheelchair patient because, ulcers are not random. If you learn to map pressure in your head or just, write it down, be like, this is red, this is red, this is where callus forms, this is where they have a history of ulcer. You can predict where a patient is at high risk of a possible wound and you can prevent them because prevention is better than cure, right? And, wheelchair patients, they don't need fewer assessments. They need actually more assessment. They need to be assessed and checked on twice a day, in my opinion, when it comes to the low extremities, and they need smarter assessments. They actually need very detailed assessments because it's not just about, oh, let me clip your toenails. You have to do a biomechanical assessment, even on a patient who is not walking. You have to remember that as a physician, okay? So let's do some quick high yield board questions when it comes to wheelchair pressure mapping and diabetic foot ulcers. So, a non ambulatory diabetic patient with a heel ulcer, the caregiver reports that the patient doesn't walk. What is the most likely contributing factor to this patient's heel ulcer? A, repetitive gait cycles. B, shear forces from ambulation. C, static pressure from the heel from the foot plate contact. D, excessive plantar forefoot loading, or E, acute trauma? The answer is going to be C, static pressure on the heel from the foot plate contact. So wheelchair patients develop ulcers from static prolonged pressure, especially at the heel due to the foot plates or dangling heels or rigid supports, not from walking. Next question. A wheelchair bound patient with diabetes develops a painful nucleated hyperkeratotic lesion on the lateral aspect of the fifth digit. Which deformity best explains this finding? This is a very easy one. A, is it hallux valgus? B, hammer toe? C, adductor varus? D, claw toe? Or E, Taylor's bunion? It's going to be C, adductor varus, because adductor varus rotates the fifth toe medially and plantarly, shifting the pressure to the lateral skin, especially in patients who have neuropathy. Next question. Why are wheelchair related foot ulcers often more dangerous than ulcers on ambulatory pressure patient injuries? A, because higher peak pressures. B, because of increased shear forces. C, due to lack of footwear protection. D, because systolic pressure causes prolonged capillary occlusion. Or E, increased friction during transfers. The answer is D. So static pressure collapses the capillaries for extended periods of time, and that causes or that results in ischemia, tissue necrosis, especially in neuropathic patients who lack the protective sensation, okay? Next question. In a wheelchair-bound diabetic patient, they have a recurrent callus in the same location, mostly or strongly indicates what? A, adequate offloading. Absolutely not. We already know that. B, normal pressure adaptation. C, chronic pressure memory. D, improved perfusion. Or E, effective bracing. The answer is C. Callus formation represents pressure history. Recurrent callus equals unresolved pressure, which equals a pre-ulcerative lesion. Now, next question. A non-ambulatory wheelchair patient with a diabetic foot ulcer, the primary role of the AFO is to what? A, improve the gait efficiency. B, increase the walking endurance. C, correct the limb length discrepancy. D, redistribute the pressure and stabilize the deformity. Or E, increase the plantar flexion strength. The answer is D. For wheelchair patients, the AFO is for pressure control and positioning, not really for gait because it's non-ambulatory patient. Next, which factor most contributes to heel ulcer formation in a seated diabetic patient? Is it A, excessive forefoot loading, B, poor shoe gear, C, rigid foot plate contact with prolonged sitting, D, high body mass index alone, or E, acute vascular occlusion? The answer is C, rigid foot plate contact with prolonged sitting. So a rigid foot plate plus prolonged sitting plus neuropathy causes continuous heel pressure. Okay. Next question. A patient develops a plantar flexion contracture after prolonged wheelchair use. What is the primary consequence regarding pressure distribution? Is it A, reduced heel pressure? Is it B, increased dorsal pressure? Is it C, increased posterior heel and forefoot pressure? Is it D, decrease lateral column loading, or is it E, improve midfoot stability? The answer is C. So, a patient that develops a plantar contracture after a prolonged wheelchair use, the primary consequence is going to be an increased posterior heel and forefoot pressure. Plantar flexion, plantar flexion contractures increase heel and forefoot pressure, which will worsen the risk of ulceration along those areas. Why are wheelchair-related foot ulcers often deeper than they initially appear? Is it A, because there is increased bacterial virulence, B, excessive shear forces, C, static ischemia causing deep tissue injury before skin breakdown, D, poor hygiene, or E, rapid epithelial turnover? The answer is C, static pressure causes deep ischemic injury before surface breakdown becomes visible. Two more and we're done. Next question. A wheelchair patient develops a new ulcer after receiving an offloading device. What is the most likely reason? Because of the device in my head, but is it A, device noncompliance, B, infection, C, pressure redistribution to a new site, D, improved mobility, or E, allergic reaction? And actually, that does happen with some patients. But the answer is C, pressure redistribution to a new site. So offloading doesn't remove pressure. People always need to remember that offloading actually just moves the pressure. So failure occurs when the new pressure site is not anticipated or monitored. Okay? Next, wheelchair bound patient that has diabetes has a heel ulcer with a positive probe to bone test. And that's something I really don't want to hear because the calcaneus, having osteomyelitis of the calcaneus is very extremely hard to treat. They usually, and we'll get into that in the future. But what is the most appropriate interpretation? It's a positive probe to bone test on a heel ulcer? Is it A, colonization, B, pressure injury only, C, osteomyelitis until proven otherwise, D, Charcot arthropathy, or E, venous ulcer? It is C, unfortunately, a positive probe to bone test. Remember, it has a high specificity. Y'all have to help. I am so sorry for the tongue tie. But long story short, it's osteomyelitis until proven otherwise, but most likely it is, okay? Regardless of the patient's ambulation status. I guess we can do a few more. The ulcer location that is most commonly missed in wheelchair patients is what? A, the plantar forefoot, B, the medial malleolus, C, the lateral fifth toe, D, the hallux pulp, or E, the dorsal midfoot. The answer is C, the lateral fifth toe. So the lateral fifth toe is a classic missed pressure site due to the external rotation and the ductal varus. What condition most accelerates pressure-induced tissue breakdown in wheelchair patients? Is it A, hypertension, B, hyperlipidemia, C, diabetic neuropathy, D, mild anemia, or E, obesity? The answer is C. So neuropathy, remember it removes protective sensation. That means that the patient won't feel it, and there will be no change in the patient's position, so that will cause prolonged pressure, and pressure-induced tissue breakdown will be the result. Last question is going to be, which finding suggests a pressure mapping failure rather than infection? A, purulent drainage, B, crepitus, C, a recurrent ulcer in the identical location despite offloading, D, a fever, or E, leukocytosis. Its answer is C. A recurrent ulcer in the same site indicates unresolved mechanical pressure, not infection. It could get infected, but I'm just saying if it keeps on coming in the same site, yeah, we got to address the biomechanics along that area, okay? So, boards don't care if the patient walks or not. They just care about the location, okay? You care about that it happens and why. Remember the whole thing about being a physician, you have to ask why, okay? And they care if the pressure makes sense. So, you have to remember wheelchair ulcers are static, they're predictable, and they can be preventable. They're quite preventable. And if you can pressure map in your head the patient that is in the wheelchair, you can answer these questions, you can actually save limbs. And this is Diabetic Foot Files. This is Dr. G, and take care of your feet because they take care of you.